Okay, guys, good morning, and thanks for joining us today. Today, I'm going to talk about normal and abnormal upper airway development. If you guys don't know me already, I'm adjunct professor with Stanford in sleep medicine, and I'd be happy to follow through with any questions either today or after the session, whatever works for you guys. So I had the privilege of meeting the late Dr. Gimino way back in 2015. And, this is a interesting, complex area, but it's not that complicated. And we'll have to differentiate between complexity on the one side and how people sometimes complicate the understanding of the mechanisms and principles that we're working with. So it's an area of active research and development, and it's just a great time to be working in this arena. When we think about upper airway development, we think about the migration of neural crest cells into the developing phase pharyngeal region during neural tube formation. This gives rise to a fourth embryonic tissue, mesenchyme. It's a connective tissue, and from that, various structures in the head and neck region are formed, including the upper airway. So if we think specifically from the third arch mesenchyme, you get the stylopharyngeus muscle. And then from the fourth arch mesenchyme, the constrictors of the pharynx, which are predominantly, the muscles that form the upper airway tube, if you will. And so around the same time, you're getting the development of the tongue from several pharyngeal arch components. The anterior one-third of the tongue, two-thirds of the tongue is developed from the first arch mesenchyme. The posterior one-third of the tongue is developed from the third pharyngeal arch, and the very posterior part of the tongue, epiglottis, folliculae, that type of region, they are derived from the fourth arch components. And in between all of that, you've got the first pouch, and from that region, the endoderm starts to, the underlying mesenchyme, the endoderm proliferates to give rise to the palatine tonsils. You already know that from your embryology development way back when, but it's just good to know the basis of some of the clinical claims that we start to make as we move ahead. So if we look at the development of the tongue, one of the things that we have to explain is the clinical presentation of the lingual frenum. During development, you get coordinated cell death at very specific regions. And one of those is in the oronasal membrane, which separates the developing nasal cavity from the underlying oral cavity. So here's the apoptosis, the programmed cell death, which allows the nasal cavity to be continuous with the oral cavity. And then later on, you develop a secondary palate, which then separates off the nasal breathing from oral functions such as speech and swallowing and mastication. Now, also on the floor of the mouth, you get a similar type of process, apoptosis. It spreads from the lateral to the medial direction. And so when you have that cell death occurring in the floor of the mouth, the tongue is separated from the floor of the mouth, and a little tag tissue is sometimes left behind in the midline, and that's the lingual frenum. And this is the patient you can see from the front view and from the side view. And this same patient, once they've had a frenectomy, you can see that there's been a change in tongue mobility or tongue position or tongue shape. So that's kind of interesting. So here's a study that looked at the lingual frenum and the idea of sleep apnea, obstructive sleep apnea in children. And what it was noted is that in non-obese children who have a diagnosis of sleep apnea, they have a poor attention span, they are predominantly mouth breathers, and they have this short lingual frenum, a low tongue position. And so that's the area of investigation. And in passing, premature babies, kids who are born prematurely, also have a short lingual frenum. So here was looking at, the possible role of the frenum. And so what they had done in some of these children diagnosed with apnea is to do an adenotonsillectomy, a TNA. That was performed without doing a frenectomy. And when they did that, the apnea-hypopnea index decreased, it was improved. They then did the same thing, except that frenectomy was performed in this other case. But what you found is that children with the frenectomy did not lead to a normalization of the AHI. So even if you do a frenectomy or you don't do a frenectomy, there doesn't seem to be a change in the apnea-hypopnea index. So that's kind of interesting. And what kind of intrigued me was the conclusions that this paper had reached about the influence of the short frenum on orofacial growth. It seemed to be having a disproportionate influence on facial growth. And also the conclusion was kind of interesting, saying that a short lingual frenum leads to abnormal facial growth as a risk factor for development of sleep apnea or sleep disordered breathing. And I found that the evidence, the current evidence for that is pretty weak. Of course, it's available for further investigation, but I can't find any convincing evidence at this point. So why is it a big deal about this short lingual frenum? Well, the public makes use of information coming out from these journals, and this is a news report that appeared in the New York Times 2023 last year, and it claimed that dentists and lactation consultants were pushing tongue releases simply because of the kind of revenue it would generate in their offices. And so there's a bit of a controversy in terms of what is the benefit of doing these frenectomies in these children, and is there really a health kind of advantage that we can be receiving? So we think about early postnatal development of the upper airway, and the big difference here is that when the child is born, there's these physiological changes as you move away from placental to external oxygenation. The physiological changes that occur include, closure of the umbilical artery, closure of the ductus venosus, ductus arteriosus also closes, as does the foramen ovale. So you have the arterial and venous systems for oxygenation in the body there. So that's kind of interesting. But if you look at the morphological changes that occur around the same time, these two kind of efforts are coordinated. And so this child has to be able to breathe and feed simultaneously right after birth. And what you find in these newborn babies is that the primary palate is pretty well developed in these children. The tongue is also extremely well developed in babies. And so what it is that the anatomical and physiological system is set up to change from oxygenation to external oxygenation and allow breathing to occur and feed. And if you look very carefully at the back, the distance between the tip of the uvula and the epiglottis is pretty small. They're very close together in these newborn children. So the bottom line here is that neonates are capable of breathing through the nose and swallowing with the tongue simultaneously whilst breastfeeding, whilst suckling, whilst nursing. And so we really have to ask the question, if that epiglottis and that tip of the uvula are so close together, how would a thin strip of tissue, the midline of the anterior side of the tongue, how would that cause airway obstruction in neonates? It's a kind of interesting question. And so you see the changes that occur with maturation. So here's a newborn on the left side of the screen, and look at the adult airway on the right side. And the striking difference is that the distance between the epiglottis and the tip of the uvula has increased. It's increased phenomenally significantly. So looking at a newborn, looking at the larynx specifically, it's positioned higher than in the adult. Here, the epiglottis is in contact with the soft palate. And here's an edentulous adult. In other words, this person had no teeth, or the teeth taken out. But you can see that the distance between the tip of the uvula here and the epiglottis is a pretty significant distance, which means that adults can't breathe and swallow at the same time. That's part of the gag reflex, as you know. And so the mechanism of feeding and breathing do differ both in newborn and adult patients. And part of that difference arises from the descent of the larynx. And so if you look on the left side, here's the position of the hyoid bone in a young neonate, a young child. And as growth occurs, the hyoid bone tends to descend, the larynx descends. And by the time you reach an adult size, the hyoid bone has kind of descended, it's gone further down. And you can see that whilst those morphological changes were occurring, the distance between the uvular tip and the epiglottis has been increasing all of this time. So interesting difference between both the morphologic and physiologic changes in neonates compared to adults. Why is this significant? Well, the descent of the larynx may be associated with SIDS, sudden infant death syndrome. There's several studies showing that some of these babies are, in at risk. And one of the ideas is to put the baby to sleep, back to sleep, lying on the back of the head is in the crib. And the idea is to prevent SIDS from occurring. This recent study here showed a potential biomarker, which is butyryl cholinesterase, and they've measured that out of this biomarker 2 to 3 days after birth, and also in children who died of SIDS. And what they found was that there was a significant difference between the two groups. So maybe SIDS is related to an abnormality of the motor neurons affecting voluntary movements. We know that changes occur in the muscle physiology during sleep, and maybe that's a risk factor for some of these children, babies, dying from SIDS. The idea of putting babies to sleep back on the backs is a good idea. It decreases the incidence of SIDS. The downside is that some of these children can develop deformational plagiocephaly, also known as positional plagiocephaly, where the back of the head, the occipital region, becomes flattened out because the child is lying on the prolonged periods of time, including in child seats in cars, that kind of stuff. So it's really a question of weighing the pros and cons, the risks and the benefits. So looking at the human airway, the general growth pattern for the human face is downwards and forwards. And so you'll see here that jaws are developing, the face is getting bigger in a vertical direction, but it's also moving kind of slightly forwards, allowing those teeth to erupt into position. And if you had a mouth breather with abnormal breathing, abnormal function, the face grows downwards predominantly instead of going downwards and forwards. And the patient with a reverse swallow, where again the physiology has been changed to get this increased overjet, so the upper teeth seem to be sticking out. Actually, what's happened is the face has grown downwards predominantly and also backwards. Now, these animations are interesting, but they're not quite complete because they haven't really included the wisdom teeth. And the wisdom teeth are kind of important, in my opinion, because they are closest to the pharyngeal airway. So here's a question. Association between cephalometric measurements and severity of OSA in children and adults. So a cephalometric X-ray radiograph is a lateral radiograph taken, with positioning. And in children aged between 6 to 18 years old, the position of the hyoid bone is kind of associated with OSA in males, both boys and men. The length of the soft palate and the mandibular angle relates with AHI in males. Now, the mandibular angle is kind of interesting because not all mandibles are the same. And this is an important kind of feature because one of the go-to clinical protocols for dental sleep medicine is to protrude the mandible or to place the mandible in the forward position. Now, the thing about the mandible is that the mandibular angle, if it's high, then there's an increased chance of getting a anterior open bite where the teeth don't meet together. So when we look at the cephalometric measurements, we start getting additional information. We already know that a mandible that is retrognathic, that's kind of placed further back, it looks like you've got a receding chin, is associated with AHI changes both in pediatric females and adult males also. So whilst this facial growth and development is occurring, the upper airway is also growing as well. This kind of ties into an idea called the spatial matrix hypothesis. So the idea there is that these components have to fit into a matrix in three-dimensional space over time. And those components include hard tissues like the jaw bones, soft tissues such as the tongue. Number three, obviously the functional spaces, which are the upper airway, and of course the dental tissue, which are the teeth. But if we specifically look at the upper airway, there's incremental growth between the age of about 6 to 18 years. You can see it in the green line here. A growth plateau occurs between the age of about 6 to 9 years. Then there's growth acceleration between 9 to 16 years. There's another plateau here between the age of 16 to 21. And then after the age of adulthood, you start to get a slow decline in the growth of the airway as you get into adulthood and into aging and maturation. Now, whilst the airway is growing, you've also got the surrounding tissues, soft tissues, and how does that vary in children who are non-snoring children? And then this study here is an MRI analysis was done. What they found is that the mean cross-sectional area, CSA, and the sagittal dimension of the larynx increased as these children got older. The volume of the tongue and the volume part also increased. And then the development of the upper airway during that peak period of growth was seen mostly in the transverse dimension. So it got wider. Now that's interesting for us to know because we want to match the clinical behavior of this structure with its development and with its function. So again, referring back to dental sleep medicine, one of the things that's used here is a mandibular advancement splint. And you can see that in this responder, when the mandible was moved forwards, the airway did get wider in that medial-lateral dimension. The figure below shows a non-responder. So in this case, the mandible was manipulated forwards by the dentist, but there was no change in the upper airway. So how do we explain that? Well, you have to think about not only the development, but also the functional aspects of the upper airway. So in children who've got adenoids, the way they form a seal between the oropharynx is to use the adenoids and the back of the tongue here. As you get older, some patients have a anterior-posterior pattern of closure of the velopharyngeal isthmus. That's the narrowing between the soft palate and the back of the pharynx. Some patients have a sphincter kind of mechanism, almost like a circular concentric closure of the upper airway. And some patients close their upper airway in a medial-lateral direction. So if you have a patient who has a diagnosis of sleep apnea and their upper airway closes in an anterior-posterior manner, the chances are that mandibular manipulation will be of benefit to them. If you've got a patient who opens their airway in a medial lateral direction, you can advance that mandible as much as you like, but the fiber orientation will not allow you to actually open the airway. And if you've got the sphincter type, concentric opening and closing, there will be a kind of partial response. And so this is interesting to know is not just the actual structure, but how is the behavior of the upper airway going to affect the clinical response? So we're talking about upper airway development. As I mentioned at the beginning, it's kind of complex, but it's not complicated. We can take this kind of flow chart kindly provided by Dr. Huang, and we can look at some of the aspects here and look at some of the controversial parts here. We're looking at the genetics of upper airway development, looking at connective tissue diseases, and specifically intermaxillary synchondroses are affecting abnormal orofacial growth, maxillomandibular deficiency, leading to abnormal breathing, and so on and so forth. So here's an idea to look at this intermaxillary synchondrosis. And so I went back and I went to look at the literature and I was trying to find the intermaxillary synchondrosis. What I found is that we have an intermaxillary suture in humans. We definitely have a intermaxillary suture. It's at the front of the face here. It goes way back into the midline of the palate. But we do not have a synchondrosis. And so when we start explaining the mechanisms of correction, we have to have a correlation between our known clinical and basic scientific knowledge to make sure it all coincides. So when you think about a cranial vault, A suture is a joint found between two bones that develop by intramembranous ossification. And that's what you're seeing here. The intermaxillary suture is an example of that. A synchondrosis is a joint found between two bones that develop via endochondral ossification. In other words, there's a cartilage plate found like a long bone. And so the bottom line here is the suture, the intermaxillary suture, is not a synchondrosis. There is no cartilage there. The mechanism of development is not dependent on cartilage. And we can talk about sutural homeostasis. When you stretch that suture, the stem cells will differentiate to lay down new bone. And that most likely is the pattern or the mechanism of palatal expansion. So let's look at palatal expansion. Here's a study that came out very recently, about a year ago. And what did these people say? They said that rapid maxillary expansion following surgery to release the tendon is a well-known treatment in orthodontics. So again, I went back and looked at this very carefully, and that is an erroneous statement. It's incorrect. We have to make sure that what we're saying is actually factually is the evidence for it. So I actually did write back to the journal here to say that there was the error in the paper. And orthodontists know there is no tendon in the human maxilla. It's a suture. It's a sutural system. The maxilla is developed from intramembranous ossification, and the sutures provide a niche or a niche for stem cell differentiation. Looking at craniofacial and upper air development, it's a complex choreography. There's mesenchymal epithelial interactions. There's the production of growth factors, transcription factors. It's a tightly regulated sequence, temporospatial patterning. And if there's an interruption of this process or a mutation, you can get abnormalities of both the face and the upper airway. So here's a young child here. He's got a condition called craniofacial microsomia, sometimes called hemifacial microsomia. And the underlying condition here is that the mandible on one side has not grown and developed as you would like to say. So here's an 11-year-old boy. This study was done in 2006 at the University of Puerto Rico, Center for Craniofacial Disorders. And we can look at the airway length and the airway volume, and we can see that both those parameters are decreased. When you compare that with a normal case, you can see that the child on the right has craniofacial microsomia. The child on my left on the screen has a normal airway, and you can see that both the length and the volume is decreased, which is kind of coincides with the craniofacial abnormality that we saw in the child with craniofacial microsomia. So when we are screening for obstructive sleep apnea, we can look at children with severe craniofacial anomalies. These are things like Cruzone syndrome, Apert syndrome, Goldeneye syndrome, Treacher-Collins, Pfeiffer syndrome, a whole bunch of these craniosynostoses. And what you find is that there's an increased risk of obstructive sleep apnea. Craniosynostoses are premature fusion of the craniofacial sutures, and you can see that there's a high prevalence of symptoms of airway obstruction and obstructive sleep apnea in these cases. So this is a genetic mutation. It's the FGF superfamily of growth factors. And if that gene is mutated, then the sutures can't grow, they're synostose, they undergo premature fusion, and the craniofacial growth is distorted. And the treatment for these children will be some kind of surgical intervention because the mechanism for the sutural growth has been lost through genetic mutation. Now, looking at craniofacial and upper airway development in patients with Treacher-Collins syndrome, these children have a smaller cranial base, a smaller maxilla, a smaller nose, a nasal airway, and a reduced upper airway volume compared to controls. And so how we're going to treat these children, because we know there's an increased risk of obstructive sleep apnea. In this study here, looking at children with syndromic craniosynostosis, they felt that CPAP was an effective and acceptable method of treating severe OSA in these children. I'm fine with that, except that, using a CPAP, it may interfere with further growth and development of the craniofacial region. And so here's a study that we did. This is the Center for Craniofacial Disorders, University of Puerto Rico. And we were looking at children with specific craniofacial anomalies, craniosynostoses. And you can see that the child on the left here, pre-treatment, there's a mid-facial hypoplasia. The mid-face has not grown and developed as required or as expected. And so surgery was done in this case, distraction osteogenesis, to actually relocate that face into a forward position. And this photograph just shows the improved facial soft tissue profile. Here's the MRI scans prior to distraction and afterwards. You can see the bony deficiency on this face here. There's a lack of skeletal tissue. This is the midfacial hyperplasia. The sutures here were synostosed and could not grow. And you can see that post-distraction, there's been a change in shape, size, and volume of the midface here. And you can see the site where the osteotomy was done way back here. The whole face is brought forwards and allowed to develop in a different spatial matrix. So if you do the study, it was done in 2006. What we suggested is that the results from midfacial distraction osteogenesis are similar to maxillomandibular advancement. The difference here that the distraction is done over a period of about 6 weeks, as opposed to a single step maxillomandibular advancement. And looking at the composite of this group of children, adolescents, the red area shows improved facial profile, increased midfacial bone volume, and there's a red area right about here, and that represents the upper airway. And so in these children using this MRI data, this is finite element analysis to say what happened. After correcting for size, the upper airway showed a dramatic increase in size according to this analysis. This paper just came out this year. This is 2024, clinical analysis of Lafore distraction, osteogenesis for obstructive sleep apnea in pediatric patients with syndromic craniosynostosis. And the long story real short is that the osteotomy and the distraction osteogenesis were effective in enlarging the upper airway width and improving sleep apnea in these types of children. So we could use CPAP in this population group. Another alternative would be to do some form of distraction osteogenesis to improve the facial profile, as well as improving the functional aspects of the upper airway during breathing and sleep. So again, looking at abnormal development of the upper airway here, we are going to look at another component here, which is dental agenesis, crowding of the teeth, and impaction. And specifically, what's being pointed out here is in dental agenesis, we have to look at things about, the dental alveolar growth centers. And these dental alveolar growth centers give rise to abnormal orofacial growth, maxillofacial deficiency, abnormal breathing, and so on and so forth. So that is an area for discussion here. So looking at this paper, which was published in 2016, Missing Teeth and Pediatric Obstructive Sleep Apnea. So when I read the paper, they had 32 children with dental agenesis, the lack of teeth here. And then in the results, now they've got 31 children with dental agenesis. 11 of those had early dental distractions. All children with missing teeth was 43. The numbers don't add up. And so when I read these papers, I'm wondering what happened to this patient population. Maybe it was a typo, but that's fine. So let's look at the conclusions here, is that the children with missing teeth had a higher presence of increased apnea-hypopnea index. And so the conclusion was that alveolar bone growth is dependent on the presence of teeth that supports it, and that a smaller oral cavity is known to predispose to the collapse of the upper airway during sleep. I find that kind of surprising. I could not find any data in the literature so far that shows a correlation between a smaller oral cavity and, upper airway collapse. Maybe the literature is there. I couldn't find it. Here's a study that came out around the same time, and it's saying that there's no evidence, no relationship between tooth extraction and sleep apnea. It's a pretty large study, 5,500 charts were reviewed, and in their conclusion was that there's no correlation between tooth extraction, a lack of teeth, and a increased risk of airway, breathing, and sleep issues. Both of these studies actually did not look at the wisdom teeth, and I think that the human genetic blueprint, is 2 eyes, 10 fingers, and 32 teeth. And so it's not a coincidence that we have the propensity, the genetic potential to produce 32 teeth. That is the optimal human body pattern for survival. And so I think that a crucial part of the equation is to look at wisdom teeth. Here's another study here looking at the effect of premolar extraction on the upper airway in adults and adolescents. In the adult group, the nasopharynx, oropharynx showed no significant change. In the adolescent group, the nasopharynx and the oropharynx volume and the minimum cross-section area of the upper airway increased in a non-significant manner. I'm not sure what they mean by that. It kind of seems kind of contradictory in terms of what they're saying. The conclusion was that the evidence indicates that tooth extraction does not increase the risk of upper airway collapse in adults or adult patients. Again, interesting conclusion. I'm not sure how they measured airway collapse. This was taken from meta-analysis. So I'm not sure how they are reaching some of these conclusions. It's a very interesting observation. I think it requires further investigation. What about the wisdom teeth? So we talked about dental agenesis, and we can look at this study. It took 10 years. And we're looking at the idea that alveolar bone is not a growth center. So this is the same child followed for 10 years from 2011 to 2021. And you can see that as a child, this child has developed 3 of the 4 wisdom teeth. One of the wisdom teeth did not develop. Here's the dental agenesis. But if you look very carefully, you can clearly see the alveolar bone is clearly present here. And the other side, the tooth has erupted into place. And so the idea that we have these, quote, alveolar bone growth centers, it's an outdated phenomenon or an outdated concept. Ossification occurs during development at sites of single track duction due to temporospatial patterning. In other words, at certain places at certain times, certain genes are switched on. Those genes will trigger a developmental mechanism. In this example, it would be tooth development followed by tooth eruption. If those genes were mutated or there was an epigenetic interference, then you get a lack of tooth formation. However, the genes for bone formation were not affected, and therefore the bone is going to develop as expected. So looking at a further part here, looking at the idea of a high and narrow palate, how does that affect the incidence or risk of sleep apnea? Here's a study using MRI. It looked at the volume of the upper airway and the pharyngeal lymphoid tissue in premature babies and in term infants. The volumes of the upper airway tonsillitis noise were measured. And in this group of about 96, 40 were preterm babies and 47 were term babies. The average volume for the term baby showed larger nasopharyngeal and oropharyngeal volumes. And what the study showed is that OSA is disproportionately more common in children who are born prematurely. And the children born at term have larger nasopharyngeal and oropharyngeal volumes. So here's a child that's born at term, a mature infant, and you can see a nice broad flat palate. And here's a premature child here, a baby here, and you can see the narrow, high vaulted palate here. And if you look at the actual study itself, You can look at the full-term kids did not have sleep apnea. The kids who were born prematurely did have sleep apnea, and the kids who had the narrow, high-voltage palate, they had a slightly more severe index of AHI compared to the preterm kids who did not have a narrow, high palate, hard palate. So, palatal morphology does come into the equation in terms of how these children will be breathing. And so when we think about, what's going to happen here, this is a very interesting paper called Mind the Gap, Genetic Manipulation of Basic Cranial Growth within Synchondroses Modulates Calvarian Facial Shape in Mice Through Epigenetic Interactions. Very interesting paper because the genetic abnormality here is occurring in the cranial base. However, the facial shape changes through epigenetic interactions. If you remember, the calvaria and the maxilla are sutural systems as opposed to the cranial base, which is a synchondrosis, essentially cartilaginous. And so here's an idea that you can change the facial shape, including the palate, through epigenetic interactions. If you look at these adults now who have been diagnosed with OSA, compare them to a group of adults, matched adults who do not have OSA, you correct for size, so you get rid of the size variation, and then you superimpose the two the average shapes on each of the average geometries. What the study showed is you get concentric collapse of the palate in these patients with sleep apnea. And so, yes, so the idea that a narrow palate is somehow associated with sleep apnea seems to be gaining some momentum. This is a case study that was published a while back. You can see some teeth were extracted, but post-treatment, the palate did get wider by 34 to 39 millimeters. And in this single case, the upper airway volume increased by about 70% before and after treatment. Here's the 3D cone beam. You can see a kind of funnel-shaped narrow airway pre-treatment. And after 15 months, the airway has changed shape, size, and volume. No device in the patient's mouth. And when the sleep study was done, from an initial apnea-hypopnea index of about 24 events per hour, it's been decreased to about 3. So if you look at some of the ideas here is that the available published studies show evidence of anatomic changes in the airway, either with surgery or with dental appliances, and they may be useful in the treatment of sleep apnea. What else do we have here? The soft tissue, the palatine tonsils, the adenoids, how do they affect the upper airway during development? Well, the pattern of lymphatic development is that the lymphoid tissue tends to grow rapidly between the age of 8 to about 16 years. And here's the peak occurring here. We're concerned with Walde's lymphatic ring, which is that ring of lymphoid tissue that surrounds the oropharynx. And we've got in the midline, you've got the adenoid tonsils, the pharyngeal tonsils. You've got the small tubal tonsils around the opening of the auditory tube. You've got the palatine tonsils, as you know, on either side of the oropharynx. And the posterior one-third of the tongue, you've got the lingual tonsil. And if we look here, we know the function of tonsillar tissue is to protect the upper airway and the pharynx, to remove the toxic products, initiate the immune response. You've seen cases where the tonsils are highly infected and inflamed. And you can see these hypertrophic palatine tonsils, which are kissing tonsils touching in the midline here. And you're also familiar with the adenoids, which are behind the uvula on the posterior pharyngeal wall, the part of Walde's lymphatic ring here. And you can see them very clearly on orthodontic lateral cephalometric X-ray. You can see how much obstruction is occurring behind the nose here at the posterior nasal aperture by this mass of hypertrophied tissue. Another way to look at this is to use endoscopy. You put the endoscope, as you know, through the nose here, look behind the palate, and you can see the adenoids as you go further down. And you can see them both, statically and in function during, for example, speech. Another way to visualize them is use a 3D cone beam. And you can see here the posterior nasal aperture, how it's been reduced in cross-sectional area. The tissue behind it, all that stuff is impinging onto that space, and all of that is adenoidal tissue. So you can get airway obstruction behind the nasal maxillary complex due to hypertrophy of the adenoids. So typically, the tonsils usually regress by the age of about 16 or so. If you've got allergic hypertrophy, it can cause both snoring, upper obstruction, and it can cause sleep apnea. And some of the treatments that you can think about are tonsillectomy, a partial removal of the tonsils, tonsillectomy, removing the palatine tonsils, or TNA, where you remove both the tonsils and the adenoids in some of these cases. But what you can see here is that kind of swelling here of the adenoids. So when you think about OSA in children with or without tonsillar hypertrophy, is OSA in the parents, is it a risk factor for the development of OSA independent of tonsillar size? In this study, 124 trios were taken, parents and child, aged 16 to 18 years old. Tonsillar hypertrophy may be a cause of pediatric OSA, and if it's there, it may mask a family history that is underlying. So OSA in parents may indicate a higher risk of OSA in children without tonsillar hypertrophy. And these children need to be investigated and identified early on to see if they are at increased risk. So when you think about the mechanism of sleep disordered breathing, SDB, we've got this narrow high palate, which leads to a low tongue posture. It leads to mouth breathing and nasal disuse. And this worsening of poor nasal breathing leads to increase in the upper airway resistance. And so it's a vicious circle. So what we have here again is a change in the position of various structures. And so this is the spatial matrix hypothesis. In this case, it's the soft tissue, it's the tongue. And based on that change of position, there's a change in temporospatial patterning in terms of how these genes are going to respond to environmental factors such as swallowing, breathing, and sleep. Low tongue posture here can cause enlargement of the adenoids and tonsils. And again, that's a vicious circle. So here's a question. Does rapid palatal expansion, RPE, in children, does it help in these children who've got tonsillar hypertrophy? So here's a study that came out, the impact of rapid palatal expansion on the size of the adenoids and tonsils in children. And they were going to evaluate changing the adenoids and palatine tonsils following rapid palatal expansion. They have a control group and experienced a statistically significant decrease in both the adenoids and the tonsil volume as the children got older. There was a non-statistically significant increase in the volume from T1 to T2 for the control group. So I'm not sure what that means. So here's another one that came out, a roadmap of craniofacial growth modification in children with sleep-disordered breathing, a multidisciplinary approach. And so what this paper is suggesting is that between the ages of 0 to 8 years, children should or could have some form of removable palatal expander. Between the age of 6 to 15 years, they could have a conventional rapid palatal expander. And between the age of 10 to 35 years adulthood, they could have a mini implant assisted rapid palatal expander. And if they're older than 18 years old, they could have a surgically assisted mini implant assisted palatal expander or distraction osteogenesis maxillary expansion down. Another paper here is talking about the management of children with OSA using adenotonsillectomy, TNA. And again, this paper is a personal view. And so what we know as a rule of thumb is some patients respond well, some patients don't. And so this is part of the kind of idea is which protocol for which patient, how is the patient respond? So this is some of the ideas that we have to think about. But the kind of conclusion here is that a multi-pronged comprehensive approach to persistent OSA might achieve better results. So looking at rapid palatal expansion here, opinion changes based on the evidence as it emerges. So this group in 2013 supported the association between maxillary expansion and OSA treatment. But by 2022, they had reduced the strength of its findings. There was a lack of correlation between the morphology and the in pediatric OSA. So evidence supporting tumor pediatric OSA with rapid mass expansion mainly comes from uncontrolled case series. Whether or not rapid macular expansion improves pediatric OSA remains to be determined. And so this paper also came out quite recently, 2022. And what they're saying is that because there's deficient evidence to support rapid mass expansion, what we should do instead is watchful waiting. In other words, just allow these children to kind of deal with it, to grow up and try to grow past it. So this paper was suggesting that rapid macular expansion should not be recommended for the treatment of pediatric OSA. Agreeing with a kind of a bit of a pushback on this paper, saying, that's not a good way to proceed. I was invited to reply to that commentary, and so I did. And long story short is that, we have to use medical principles. The first approach is to do no harm. We just can't allow these children who are struggling and the parents who are struggling with condition to kind of just say, well, Jimmy boy here will grow out of it, let him just get on, because during that time, there will be educational hurdles, behavioral problems, there may be bedwetting, there'll be a lot of stuff going on. So we have to use first principles is number one is do no harm. Number two is make no assumptions. Don't assume that if we remove the tonsils or we do powerful expansion, that the condition will be resolved. But number three is be better than placebo, be better than doing nothing. So if we're going to do watchful waiting, that has to be kind of balanced with, professional kind of responsibility. We don't want the idea of supervised neglect, where these children are suffering from other, comorbid conditions, simply because we don't want to undertake rapid powerful expansion in these children. So again, I would reinforce the idea that working closely with our medical colleagues on a multidisciplinary basis is the way forwards. A lot of research development still needs to be done to find out how can pediatric OSA be best developed or best addressed, bearing in mind that the growth and development of the airway is going to be going on simultaneously during treatment. So we've just got about 5 minutes left. I'd be happy to take any questions if you have.
My question was, what was their response?
The publishers responded by publishing my correction to say that there is no tendon in the human maxilla. If there is, it'll be a scientific breakthrough and we should publish that, but there's no evidence whatsoever. Anyone who's been trained as a general dentist, an orthodontist, or a craniofacial knows the development, craniofacial development. We know the nature of the sutures. We know how we use them for clinical protocols. There is no tendon, regardless of whatever reply was given to defend that. We've got to be careful of fake news here. As I mentioned earlier on in the lecture, number one, the idea was it was a synchondrosis, which is not, because there's no cartilage in the maxilla. Therefore, we can't use a kind of a cartilaginous-based approach to grow the maxilla during expansion. Number two, it's not a tendon, and therefore we have to think, what is the nature of the expansion? And the answer is it's a suture, and sutural kind of biology has become very well kind of investigated. And as I mentioned, we have populations of stem cells, and there are stretch sensitive genes. So when these sutures are gently stretched, signal transduction occurs, and you get the formation, a cascade of cytokines being released. And the bottom line is that you get osteogenesis, the formation of new bone. And so the suture doesn't get wider because you get bone deposition, but the overall width and volume of the maxilla actually increases. And so, yeah, you can publish a reply saying, we don't agree with you. Unfortunately, the medical and scientific evidence today shows there is no tendon, no synchondrosis in the human maxilla. And if you can produce evidence to show me otherwise, I'll be very happy to look at it. I've just put a little book here that I wrote during the pandemic. some of these items are discussed in there if you want to do a little bit further reading. But you have my email, and if you have a specific question or comment, I'd be happy to talk to you about this further. I just want to thank everybody for being present here today. Thanks for the staff for putting everything together for us. And I shall be doing a follow-up lecture also towards the middle or end of June. I'm guessing it's around that time.
Thank you so much, Dr. Singh. It's always good to have you with us. Keep our brains going. Thanks again.